Hi, everyone, and welcome to Let's Talk on this bad weather day at the end of April. What's with this? When is it spring officially? Not yet, but soon. I'm Dr. Judy Regensteiner. I'm director of the Center for Women's Health Research, professor of medicine here at the Anschutz Medical Campus. And it's my pleasure to welcome you here on behalf of the Center for Women's Health Research and our partner, UC Health. The Let's Talk series, we present 4 or 5 times a year about topics of medical importance, and we're really appreciative to all of you for coming out tonight on this really not so beautiful evening. Now it's raining. I read today it could be snow, fog, thunder, and cloudy. That was the choice. Those were the choices, and I think we've had most of them. Haven't had the thunder, and that's okay. It can stay away. The Center for Women's Health Research has the mission of doing cutting-edge research in women's health and sex differences primarily in the areas of cardiovascular disease and diabetes and mental health as it impacts physical health. In addition, the second part of our mission is to mentor and fund and train young MD and PhD scientists to help them build careers in women's health and sex differences. And thirdly, why we're here tonight, is to educate the public and healthcare providers about our findings. And this is very important that you know what we are learning so that your care can be informed by the evidence-based information that we all gain from scientific endeavor. Tonight, we're going for the first time into the area of allergy, and we are very excited about that, and we really appreciate our 3 speakers. I'm going to introduce them all to you, and then one after the other they will speak. Our first speaker is Dr. Anjali Kalra, who's an instructor of medicine at our university in the area of allergy and immunology. Her clinical interests include drug allergy, asthma, urticana, which are hives, atopic dermatitis, eczema, and food allergy. Dr. Kalra's primary research interest is focused on the intersection between penicillin allergy, drug allergy, and quality improvement. And we'll look forward to her talk first. Next will be Dr. Sunita Sharma, who is an associate professor and a board-certified specialist in pulmonary and critical care medicine. Dr. Sharma specializes in the diagnosis and treatment of severe asthma. Her primary research interest is in understanding the developmental origins of asthma and how intrauterine smoke exposure impacts the development of respiratory disease in the postnatal period. Dr. Ramakrishnan, Dr. Vijay Ramakrishnan, our last speaker, is also associate professor in the Department of Otolaryngology, Head and Neck Surgery at the University of Colorado School of Medicine, where he serves as co-director of the CU's skull-based program and director of rhinology research. His interest is in chronic rhinosinusitis. So it's really exciting because these are areas that plague people, and to hear about them from experienced experts is a great thing for us. So I want to thank our speakers. I want to thank you all for coming out tonight. I want to thank the board members of the Center for Women's Health Research who are here tonight as well, and the staff of the Center for Women's Health Research, particularly Nanu Day, who is our programs manager, as well as our business specialist, Ann Kirschmar, and our deputy director, Jennifer Ingleby. So thank you all. And Dr. Kalra, will you please speak?
All right, good evening, everyone. My name is Anjali Kalra, and I am a faculty at the University of Colorado here in the Department of Allergy and Immunology. Today I'm going to be talking about environmental and food allergy. I'll be giving basic overviews of the 2 topics. These are very large topics, so I will do my best to cover all of the pertinent areas specifically pertaining to environmental and food allergy. So with regards to prevalence of environmental allergy, typically affects about 10 to 30% of children and adults in the United States, and affects 1.2 million children in 98 different countries with regards to asthma, allergic rhinitis, allergic conjunctivitis, and eczema or atopic dermatitis. With regards to economic burden, allergy involves 2.5% of all clinic visits, with specifically allergic rhinitis, accounts for 2 million lost school days, 6 million lost work days, and 28 million restricted work days per year. In terms of risk factors for allergic rhinitis, allergic conjunctivitis, and I will talk about the definitions of these conditions, there's a male predominance of both asthma and environmental allergy in childhood. And this tends to change towards a female predominance in adolescence and adulthood. This is seen for asthma, eczema, environmental allergy, as well as food allergy. Family history of allergic disease is a big risk factor, particularly maternal or mother history of allergic disease and asthma. Firstborn status, birth during pollen season, which I will discuss in the next few slides, as well as maternal exposure to tobacco smoke within the first year of life. Exposure to indoor allergens within the first year of life is also a risk factor, and this includes dust mite, cat, dog. Dust mite is not a major allergen here in Colorado, which I will also discuss going forward. In addition to growing up in a low-income urban environment, this does increase risk for allergic disease as well as asthma. So what is environmental allergy? So first I'll discuss allergic rhinitis. This includes runny nose, congestion, sneezing, postnasal drip. This can also result in sleep-disturbed breathing. We typically think of this condition as either lasting all year round, which is perennial, or seasonal, can flare in the spring, summer, and fall. I will talk about the different allergens that are prevalent in the spring, summer, fall, as well as perennial allergens. Interestingly, continual exposure to allergen actually lowers the threshold for reaction. This is called allergen priming. And this can significantly impair performance at work, at school, and can also lead to anxiety, depression, and as I mentioned, increased absences from school as well as work. On the right-hand side, you can see what we call an allergic crease, which is due to the sort of pressing against the nose from constant dripping, sneezing, itchiness of the nose. Allergic conjunctivitis, which is environmental allergy involving the eyes, is also something we commonly see and is very frequently associated with allergic rhinitis. This includes itching, tearing, burning of typically both eyes, and again can be seasonal or perennial. On the right-hand side at the bottom, you'll see an example of allergic conjunctivitis. You can see below the eyes are these lines called Denny-Morgan lines, which are sort of creases in the tissue below the eyes. Next, we have something called pollen food syndrome, also called oral allergy syndrome. This tends to impact patients who have environmental allergies, specifically to trees or weeds, which I'll get to in a moment. Typically, people will present with itching, irritation, or swelling of the mouth after eating fresh fruits and vegetables, particularly in the spring, summer, or fall. And this is due to cross-reaction between the allergens found in both pollens and certain fresh fruits and vegetables, as well as sometimes some tree nuts. Affected individuals can actually safely consume these foods in a cooked fashion because the proteins are denatured, or they kind of become not allergenic when they're cooked. Reactions that can cause trouble breathing, low blood pressure, wheezing, as well as generalized hives, very uncommon in this type of disorder. Of course, asthma, environmental allergy can be a major trigger of asthma, both indoor and outdoor allergens. And up to 50% of patients with asthma have environmental allergy, allergic rhinitis, allergic conjunctivitis. Eczema, which we also call atopic dermatitis, can also be affected by environmental allergy. So as I go forward with this talk, there are a couple of terms to be familiar with which I will be alluding to. So the first one would be mast cell, which is a type of white blood cell found throughout the body. It's important for many different functions, but specifically with regards to allergy, it is responsible for allergic response. So it contains many different chemicals, one of which includes histamine. And when histamine is released from mast cells, this can cause flushing, hives, trouble breathing, wheezing, along with numerous other symptoms that can account for allergic reaction. Next is what we call IgE or IgE mediated. So IgE, also called immunoglobulin E, is part of the immune system that is responsible for allergic reactions. Interestingly, it is also responsible for fighting against parasitic infections. But as we have become more industrialized in countries like the United States, IgE is really what we see when we think of allergic disease. So IgE will bind to these mast cells and release histamine, causing allergic reaction. I will also refer to something called sensitization, which is equivalent to what we mean by allergic to. And then antigen is also another term for allergen. And finally, immediate hypersensitivity. So this is also called IgE-mediated reaction. Essentially what it is typically within minutes to 2 hours of exposure to an allergen, whether that's environmental allergen or a food allergen or a drug allergen, you will develop symptoms like hives, trouble breathing, swelling, redness of the skin, itchy, watery eyes or nose. So allergic sensitization, as I mentioned, what happens is IgE or immunoglobulin E binds to these mast cells, releasing histamine and other chemicals responsible for the allergic reaction. So major sources of seasonal allergens. So in Colorado, this is definitely different than other parts of the country, such as the South, California, Florida, where allergens such as trees, grasses, and weeds are present perennially or year-round. In Colorado, tree pollen tends to pollinate in the early to mid-spring. So typically starting at the end of February and going through mid-May. Peak being typically March, early April. Grass pollen tends to pollinate in the late spring, so usually mid-May through early summer, mid-July, in Colorado specifically. Weed pollen tends to pollinate in the late summer and goes through the early fall until we have the first frost, so usually sometime between August through November. And climate change can affect this as well, but this does change based on location. For example, if you were living in Texas, cedar tree can actually pollinate in the wintertime. The peak pollination time is usually mid-afternoon. So in the day, you might notice your symptoms peaking in the mid-afternoon. That's because pollen tends to peak around that time. In terms of indoor allergens, so in Colorado, indoor allergens are what we call perennial allergens. So these are throughout the year. So in the wintertime, when we see patients who have itchy, watery eyes, runny nose, this is usually due to exposure from indoor allergens rather than outdoor allergens because pollens are not present in the wintertime. So here in Colorado, the major indoor allergens are pet danders. So cat, dog, or if you have exposure to other pets living in the home. Cat and dog, typically the allergen occurs in their pelt, the skin, the hair. With other types of animals like mice, for example, for example, if you have exposure through work working with mice or rats, the allergen can also be found in the urine. And at times this can be a major allergen in large cities. Dust mite, which you may have heard of, are these microscopic little mites that live on bedding and furniture. We generally do not have dust mite in Colorado. It is too dry and the altitude is too high for dust mite to survive. Dust mite is a very prevalent and major allergen in many parts of the country, west, east coast, south, particularly in really humid areas. And since we do not have that humidity in Colorado, we luckily don't have dust mite. However, if you move from another part of the country to Denver or Colorado, dust mite can survive on furniture and bedding for up to a couple of months. We generally recommend keeping the humidity down less than 50% to discourage the growth of dust mite. And then, of course, insects. Cockroach is a major allergen, but is not a major allergen in Colorado, more typical in inner city. So this is an example of irritants. Irritants can include strong odors, perfumes, dust or particles in the air, tobacco smoke, pollution, cold air, spicy foods. These are not allergens. What happens is with irritants, it can cause local irritation of the nose rather than allergic response. It can cause very similar symptoms, itchiness of the nose, sneezing, runny nose, but these are not allergens. So how do we evaluate for environmental allergy? The best method is skin prick testing. So skin prick testing, which we perform in our office routinely, is testing that's performed on the skin, typically the back for environmental allergy. What we do is we do this by a twist or prick method where we take a small device with a tiny needle, we deposit the allergen on the skin, and then prick the skin. We wait about 15 to 20 minutes to allow for the allergen to sort of penetrate the skin, and then we look at the back. And if you see here in this next photo, you can see that there is some redness and swelling. What we look for is something called a wheal, which is the circular area that you see on the patient's back, the circular sort of white-colored standing out area. And then around it is called erythema, or redness that surrounds the area. Anything greater than a 3 millimeter wheal and a 3 millimeter redness around the area is considered a positive. It is important to note that we do something called positive and negative controls. We put actual histamine on the skin, and your skin should be responsive to histamine. It should be red. And the reason why we do that is because some medications can interfere with skin testing, and we want to make sure it's a valid test. So if you are getting skin testing, you must remain off antihistamines such as Zyrtec, Allegra, Claritin, Benadryl for 5 to 7 days to avoid obtaining a false negative. And again, skin testing can be positive, but we must correlate that with clinical symptoms. So say, for example, I have a patient coming to see me who has itchy, watery eyes, runny nose in the winter time, but in the springtime, summertime, and fall, they have no symptoms and generally feel well. If their skin testing is positive to trees, that does not necessarily explain their symptoms. The next thing would be blood testing. This is specifically called serum-specific IgE testing. What it's looking at is that IgE molecule that I mentioned earlier against an allergen. So for example, if we're testing for dog, it would be looking at IgE directed against dog allergen. This test is good. It is not as good as skin testing, but is an option to be performed in the case when someone is on antihistamines or we just can't get good skin testing. Sometimes we'll check this in children because skin testing can be a little bit traumatic in our pediatric population, so it does depend on patient circumstance. It is important to note that blood testing like this can be influenced by your overall allergic state. Some patients who have eczema, for example, can have a very high IgE level because eczema can increase this in the blood. And so if you have a very high IgE level, that can falsely increase or elevate these tests. So that's something to be aware of and always discuss with your provider what those tests mean. So what do we recommend if you have environmental allergy? So the first thing we recommend would be allergen avoidance. That's the 1, 2, and 3 thing we recommend. If you are allergic to trees, weeds, or grasses, again, trees pollinate in the springtime, we recommend keeping windows and doors closed in the spring, summer, or fall, depending on what you're allergic to. We also recommend when you come back inside from being outdoors, showering, changing your clothing. That's very important. If you are allergic to pets like cat or dog, we strongly recommend keeping pets out of the bedroom. It's important to limit allergen exposure by doing this, especially since the sleep environment should be protected from allergen. Many of my patients find this very difficult, so we do recommend bathing the pets frequently, vacuuming, though this really has shown to be not significantly effective at reducing the allergen. If possible, we recommend giving your pets away or giving the pets to a good home, which I can tell you most of my patients will not do. So we try to work with them on this. In Colorado, it is not necessary to take measures to prevent dust mite. Again, dust mite is not a major allergen here, so we don't recommend putting protective cases over your pillows, washing your sheets in hot water once a week. It's just not something that really tends to affect our population. Again, pollen tend to peak in the early afternoon, so you might not want to go out during that time. You want to avoid mowing the grass or being outdoors, depending on the severity of your allergic disease. Many people will ask me about air purifiers. The data are not good to suggest that air purifiers are significantly helpful, so I recommend not spending money on air purifiers. In terms of medications, so typically we'll recommend a variety of medications depending on your specific needs. Again, I'd recommend discussing this with your provider or your physician, but typically what we recommend would be something like a nasal wash or a nasal rinse, and then 10 minutes later using a nasal spray with a steroid in it, typically fluticasone, triamcinolone, or budesonide, and I listed the brand names next to them. Usually 2 sprays in each nostril per day for an adult. Sometimes we'll add another type of nasal spray, typically called azolastine, which is an antihistamine nasal spray. So similar almost to Zyrtec and Allegra, but bottled up in a nasal spray. And these together can be effective for both runny nose, itchy, watery eyes. For people who have ongoing symptoms of itchy, watery eyes, we'll recommend an over-the-counter eye drop that has an antihistamine in it. We really do not recommend using things like Afrin on a daily basis. This can lead to worsening nasal, runny nose, and congestion. We also don't recommend using eye drops that have a similar chemical called pseudoephedrine or a similar medication like that in the eye drop, which can lead to worsening eye symptoms as well. If needed, we will also recommend something like Zyrtec or Allegra or Claritin in addition to those therapies. And then finally, other than allergen avoidance, if you are having ongoing symptoms that are not controlled with medications, we will talk about allergy shots or allergen immunotherapy. Allergen immunotherapy is the only therapy that can change the way your immune system sees an allergen. So over time, your immune system will not react so strongly to the allergen, whereas medication will not do this. There are 2 types of allergen immunotherapy. There's allergy shots, what we call subcutaneous immunotherapy, and then there are allergy tablets, which we call sublingual immunotherapy, which I will discuss shortly. So as I mentioned, the first type is subcutaneous immunotherapy or allergy shots. This therapy has been around since 1911. It is effective in our patients with allergic rhinitis and allergic conjunctivitis. Up to 70% of patients will find benefit after being on allergy shots for 3 to 5 years. Typically, what we do is we take what you are specifically allergic to and give it back to you. We start at very low doses, and then we go to higher and higher doses over time, essentially tricking your immune system into tolerating or changing the way it sees an allergen. We usually continue allergy shots 3 to 5 years, and most of our patients will have sustained benefit after being on allergy shots. In terms of sublingual immunotherapy or tablets, this has been more recently approved by the FDA. There are actually only 4 therapies that are approved. I will mention that allergy drops are not FDA approved right now for controlling environmental allergy. Their only tablets include for grass allergy, weed allergy, and dust mite allergy, which really is not significant again in our state. And this is really only good for people who only have grass allergy or only have weed allergy. Tablets like this are really not generally indicated for patients who have allergies to cats, dogs, trees, grasses, weeds, multiple things. But this is a good option for patients who are unable to come to our clinic for shots. It's a tablet you take on a daily basis, typically in the season of which you're affected. So for example, if you have grass allergy, your symptoms would be in the summer. We would usually start your tablets approximately 3 months before that and continue through the summer. We usually continue this therapy for 3 years, and many patients have sustained benefit as well. So it is very effective. We, again, indications for allergy shots and allergy tablets include allergic rhinitis, again, runny nose, itchy, watery eyes, asthma that is allergen-induced, and this is a separate topic, but venom allergy or allergy to bee stings, wasp stings, and fire ants. And this is really for patients who have anaphylaxis, which includes immediate redness of the skin, trouble breathing, swelling, vomiting, nausea after a bee sting or wasp sting. So what are the benefits? As I mentioned, many patients will have significant benefit from allergy shots or allergy tablets, reduction in runny nose, postnasal drip, which is that dripping in the back of the throat, congestion, itchy, watery eyes, reduced medication use, and improvement in asthma in patients who have allergen-induced asthma. Improvement in quality of life, and improvement will generally persist after discontinuation of therapy. It may also stop the progression of what we call atopy in children. So for example, children who have an allergy to only grass or an allergy to dog. We found in studies that potentially allergy shots may help to prevent ongoing allergies to other things. It also may reduce the risk of asthma development in children who have allergic rhinitis. And it is also cost effective when you compare the amount of days of school and work missed, as well as healthcare costs to allergy shots. So next I'm going to talk about food allergy. I'm going to briefly just talk about what food allergy is, how we diagnose food allergy, and then I'm happy to answer any additional questions on environmental or food allergy at the end of the presentation today. So IgE-mediated food allergy. We talked about IgE earlier. Again, those mast cells or allergy cells are bound to IgE. IgE binds to those and releases histamine, causing allergic reaction. So with IgE-mediated food allergy or classic food allergy, typically this is going to occur within minutes of ingestion. It occurs every time you eat the food. It can occur in some cases up to 2 hours after ingestion. It typically develops during early to late childhood, but there are certainly exceptions to this. And typically symptoms will include hives, redness of the skin, vomiting, nausea, diarrhea, wheezy or noisy breathing, low blood pressure, or swelling. And you can see examples of what food allergy looks like here in these slides. Food allergy affects 5% of adults and 8% of children. 3% of children, all children have multiple food allergies. Milk is the most common food allergen in children, 0 to 2 years. And then peanut becomes the most common at the age of 3. Risk factors for food allergy include children who have moderate to severe eczema, a parent or sibling with food allergy, birth by C-section, and breastfeeding may help to reduce the risk of development of food allergy. The most common food allergens include tree nuts, peanut, soy, fish, shellfish, egg, wheat, and cow's milk. As I mentioned, food allergy generally develops during childhood, and most children outgrow their food allergy to wheat, egg, soy, and milk. 20 to 25% of children outgrow allergy to tree nut and peanut, and shellfish allergy is not common to outgrow shellfish or fish allergy. But what I will make a point of saying is that this is a misconception. Shellfish allergy does not mean you cannot receive radio contrast. There is no cross-reactivity between shellfish or fish and iodine. So IgE-mediated food allergy does not cause the following: chronic belly or abdominal pain, bloating, nausea or diarrhea, runny nose, nasal congestion, chronic postnasal drip, chronic skin irritation or rashes during adulthood. The exception would be celiac disease, which causes a certain type of rash called dermatitis herpetiformis. This is not an allergy, but is a different type of reaction. And it does not cause chronic daily hives or swelling. So in terms of testing methods, the approved testing methods for food allergy include skin testing, blood testing, which is specifically serum-specific IgE testing to foods, and then there are some other tests that test for the specific protein, because when we're allergic to foods, we're allergic to the protein in the food. The best gold standard test for food allergy is something called an oral food challenge, which is essentially giving you the food in question. Things that are not approved for food allergy evaluation would be there's no test for identifying food intolerance other than lactose intolerance. There's no blood test that can be ordered to identify food intolerance. And there is testing available online called IgG to foods. This is not a validated test to identify food allergy or food intolerance. I see this a lot in my clinic, people coming in with positive IgGs to foods, and it is not validated. Skin prick testing, again, is the best diagnostic method for food allergy other than getting a good clinical history. There is a high false positive rate, so we only do this in people who present with the symptoms I mentioned earlier immediately after eating the food. Again, blood testing can be ordered as well, but should only be ordered in the correct clinical context, and can be falsely elevated as well. I will quickly go through this, but I will just mention that there have been a lot of advances in the area of food allergy. There have been studies over the last several years, such as the LEAP study and the LEAP-ON study, which have showed potentially that early introduction of allergenic foods in our population in children can reduce the risk of food allergy. This study was done because Jewish children in Israel had a lower incidence of peanut allergy because possibly they were receiving a peanut snack called Bamba, which had peanut protein. And they found that these children had potentially less risk for developing peanut allergy going forward. This study was initially done in children 4 to 11 months who had severe eczema, and this was specific to peanut allergy. But in general, we have now recommended 4 to 6 months of age, early introduction of allergenic foods, including wheat, soy, cow's milk, egg, peanut, tree nut, fish, and shellfish. It is very important to see the pediatrician first to make sure the child is ready to introduce food, and we recommend introducing generally fruits or something else that's a lower allergenic food first. Infants who are at higher risk for food allergy have moderate to severe eczema, sibling or parent with food allergy, a history of other allergic reaction to foods, and you should always see an allergist if you have any concern or any of these other above conditions. So today I've discussed briefly environmental allergy as well as an introduction to food allergy. These are some resources here that I find very helpful, what we call the Quad AI, or the American Academy of Asthma, Allergy, and Immunology, as well as our College of Allergy, Asthma, and Immunology, and then FAIR, which is a nice website for food allergy research and education. I will answer any questions after our next speakers. Thank you very much.
Hi, thank you so much for coming out tonight, and I'd like to thank the Center for Women's Health Research for giving me the opportunity to speak to all of you tonight. My name's Sunita Sharma. I am an associate professor in pulmonary and critical care, and I am here tonight representing the severe asthma program at the University of Colorado. Over the next 30 minutes, I'm just going to give you a very broad overview about asthma, about the developmental origins of asthma, and what we know about asthma treatment. And I will invite you to ask any questions that you have at the end, because this won't be a comprehensive overview of asthma. I have no conflicts of interest. So we're going to talk a little bit about asthma, its definition, how we diagnose it. We're going to talk about risk factors and the epidemiology of asthma. We're going to talk about asthma and pregnancy and how it impacts women. We're going to talk about the developmental origins of asthma. And finally, we're going to talk about the management strategies for the treatment of asthma, because we come a very long way in the treatment of the disease. Believe it or not, the first description of asthma was back in the 1600s. And the first description was a case series by a doctor by the name of John Floyer. And in 1698, what he identified was a group of patients who had laborious respirations. They were lifting their shoulders, and the reason they did that is because they were requiring the use of additional muscles to help them breathe, because they were quite short of breath. He described the classic description of asthma, which is the sound of wheezing, and he described the fact that these episodes were intermittent and happened infrequently over time. And while we have come very far in our understanding of asthma, what's interesting is this description remains very similar to the way we describe it today. The scary thing is if you look at the way we used to treat asthma, it was back, if you look back in the early 1900s, what we used was asthma cigarettes. And the way we treated this was to give patients these cigarettes that had strontium in it. And strontium was actually a bronchodilator. And what that medication did was if somebody inhaled this medication, it actually opened the airway, and patients felt better. Fast forward another 20 years, and in the early 1950s, what we used is adrenaline, which you see on the right, which was given through a vaporizer, and that also improved asthma symptoms. Luckily, in the last 20 years, we've had an incredible improvement in our understanding of the development of asthma and what the biology is, and we've come up with a variety of new medication treatments for the treatment of this disease. So what is asthma? It's a heterogeneous disease, and what I mean by that is if we took a room full of people that had asthma, each individual's presentation would be a little bit different. If you looked at the underlying biology and why people develop asthma, for subgroups of patients, it's very different. The key to this disease, however, is that everybody has chronic airway inflammation, and this is what causes symptoms. So when people have airway inflammation, one of the things that happens is their airway becomes narrowed, as you can see here on the right, in the asthmatic bronchiole, which is the asthmatic air tube. When people have airway inflammation, what happens is you have obstruction to airflow. So the air that we breathe in doesn't come out as well. And this is actually improved with medication therapy. And that's one of the hallmarks of this disease, is that we have treatments that actually can improve airflow obstruction. It's an incredibly prevalent disease. So if you look at asthma worldwide, there's about 300 million individuals who have the disease. 25.9 million Americans have the disease. And what's concerning is it results in the most number of missed school days for children and the most absences from work for adults, and results in about $50 billion of healthcare expenditures, and this is because people have to go to the hospital or go to their doctor, and this is in the United States alone. What we know about the natural history of this disease is actually quite interesting. I'm going to share with you some information about how we think the disease actually has intrauterine or intrauterine development. And what I will show you is that there are things that are happening during pregnancy that actually have impact in terms of the disease development later in life. There are a complex interplay of genetics and environment that result in early infant wheezing, and those individuals actually go on to develop childhood asthma. If you look at children that have asthma and this classic symptoms of wheezing and shortness of breath, as they progress into adolescence, one of three things can happen. Number one, for some individuals, the disease gets better and never becomes an issue later in life. For some people, the disease actually gets worse. And for some individuals in adolescence and early adulthood, that's when they present with the disease. Finally, into adulthood, for some individuals, the disease gets better, and for others, it actually gets markedly worse. If we look at the peak prevalence, as we heard in the last talk, it affects about 10% of children, and it's more prevalent in boys than it is in girls. However, that prevalence actually changes at the time of puberty. And after puberty, women and adolescent women also have an increase in the disease. We don't know exactly why this exists. We think it's related to sex hormones, but we don't know for sure. And we're in the process of trying to disentangle why this disproportionately affects women. The prevalence also increases into adulthood, affecting approximately 9 to 12% of adults nationwide. What we know about sex differences in asthma is what I've told you. Their prevalence is higher in young women and young female adults, but more notably, Female patients use more asthma medications because they're symptomatic. And what we know is that those individuals, women with asthma, actually use healthcare services with higher frequency. Why this occurs, we don't know for sure, and we're in the process of trying to study that. But we're looking at a combination of behavioral factors, but also looking at differences of inflammation in the inflammation of the airway that can occur, that can result in these differences overall. As I said, as we know that it impacts women in a disproportionate manner, but it impacts pregnancy as well. Asthma affects about 8% of pregnant women, and notably, of those individuals, 4% actually have an exacerbation, which means a worsening of their disease during pregnancy. The concern with that is that when patients have asthma during pregnancy, and if they have an exacerbation, it's associated with poor pregnancy outcomes. Things, for example, like spontaneous loss of the baby, preterm birth, and low birth weight. We always recommend patients that are pregnant and that have asthma are seen by a specialist so we can make sure that their asthma is under good control during their pregnancy and to decrease the risk of adverse outcomes for the baby. What we know about asthma is an incredibly complex disease. It has genetic underpinnings, so not just a single gene, but a variety of genetic variants that influence the development of asthma. We know there's a lot of environmental factors that influence the development of asthma. And then we know a lot about changes in the immune system, which I'm not going to get into tonight, but the changes in the immune system that impact inflammation in the airway and asthma susceptibility. When we look at the risk factors for asthma, they're plentiful. Environmental exposures, as we heard in the last talk, things like dust mite, animal allergens as well as outdoor exposures, including air pollution and ozone. For those of you who live in Colorado, which I assume is most of you, as you may remember last summer, we had a problem with wildfires. For a lot of asthmatics during that time frame, we had notable increases in their shortness of breath and wheezing symptoms related to that environmental exposure. The other things that we know that are influential in terms of asthma risk are things like respiratory infections, especially when they happen early in life, social stressors. So, for example, maternal stress has been implicated and is involved in asthma susceptibility. Now, if we could come up with a way to decrease stress for moms, I think we could do a lot to impact the development of a variety of different diseases. But we know, for moms in the room, I think we can all agree that it's not easy to do. Low vitamin D deficiency and low birth weight have also been shown to be risk factors for asthma susceptibility. Interestingly, C-sections have also been associated with asthma susceptibility. If you look at the change in the number of C-sections that have occurred over the last 40 years, one of the things that you'll notice, the incidence or the amount of C-sections that are being done has increased rapidly. What we think is that it actually can explain a little bit of the asthma increase prevalence over that time. So if you look at the number of C-sections and studies looking at C-sections, what we've identified is that a C-section birth actually increases the risk of asthma by 20% in the child. So the question is why that occurs. When we look at the immune system and the way the immune system is regulated, birth through a C-section doesn't predispose a child to going through the birth canal. And what we know is that there are a lot of bacteria on our skin, on our gastrointestinal tract, and in our nose that have important implications in the way our immune system regulates itself. And so when the baby does not go through the birth canal, it changes that bacterial flora. And what we have identified is that changes the baby's immune system and impacts disease risk later in life. The other thing that we know that impacts asthma susceptibility and disease risk is smoke exposure, so pregnant mothers who smoke. Now, in spite of all we know about smoking and all that we've done to try and decrease smoking rates across the country, what we know is that 13.8% of women continue to smoke during pregnancy, and that's in states like Colorado, for example. In other states, notably states in the South, for example, and in some states in the Midwest, that percentage is actually higher, with about 38 to 40% of women smoking during pregnancy. What we know is that intrauterine smoke exposure impacts the baby in a variety of ways. It increases their risk for wheezing in the infant time frame and has been associated with asthma as the child continues to age. So we know these are major risk factors for the disease, but one of the things that's been very impactful in terms of research in this field is the potential of blunting the impact of intrauterine smoke exposure in the child. So in women, this was an incredible study from Oregon Health Sciences Center by Cindy McAvoy and colleagues, where they gave women who were pregnant smokers vitamin C. And what we know about vitamin C is that it's an antioxidant and has relatively minimal risk in terms of toxicity. So when they gave pregnant women who continued to smoke, when they gave them vitamin C, what they noted is that for the children whose mothers received vitamin C, it resulted in a significant improvement in their lung function, in the baby's lung function, and that decreased the risk of wheeze and asthma in the postnatal period. And that effect actually persisted until 5 years of life. So this is where research has an incredible role in terms of determining the ways we may blunt the impact of environmental exposures on the development of subsequent disease. The other thing that we know that decreases the risk for childhood asthma and later adult onset asthma is breastfeeding. So breastfeeding varies by duration. About 82% of infants are breastfed at the time of birth, and these numbers drop these numbers drop over that first year to about 34% who continue to be breastfed at 1 year. What we know is that breast milk provides early passive immunity, and that it's productive in a variety of studies in terms of blunting asthma risk. The American Academy of Pediatrics actually recommends exclusive breastfeeding for the first 6 months of life. And then after that, between 6 months and 1 year, the AAP recommends mixed feeding, including breast milk, for the first year. So if you look at the epidemiologic data, there are now numerous studies suggesting that breast milk reduces asthma risk for children. The other interesting little bit of food for thought is also a concept called the hygiene hypothesis. And this is the idea that in industrialized countries, like the United States, for example, the presence of asthma is actually higher than many of the developing countries. And the thought is that early exposure to environmental allergens, things like cattle, pigs, and poultry, actually reduces the risk for childhood asthma. So children living in rural areas, for example, who've grown up on farms and had exposures to these different types of animals, have a lower risk of developing allergies and asthma later in life. So what are the symptoms of asthma, and what are the things that are concerning? When we see an asthmatic in clinic, the symptoms that they have are wheeze, shortness of breath, chest tightness, and cough. And the important things about these symptoms is that they vary in time and they vary in intensity. And what's interesting about the symptoms of this disease is that they're most notable in the evening hours and the early morning periods. And when people have symptoms at night and in the early morning timeframes, it's concerning for untreated disease. So how do we make the diagnosis? This is Nancy Perez, who's one of our asthma clinical research coordinators, who's showing us how we make the diagnosis. And this is pulmonary function testing. And so what we do is we put you in a machine, and we have you take a big deep breath in, and you blow out as hard and fast as you can. And the reason we get these tests is because it gives us the best sense of what's happening in terms of your lung health. Now, what we see when we take somebody with abnormal lung disease like asthma, if you take a big deep breath in, you blow out as hard and fast as you can, one of the things that we can see is in normal individuals, because the airway is normal and there's no inflammation in the airway, as you take a big deep breath in and you blow out as hard and fast as you can, there's no obstruction to the airflow coming out. So what you breathe in comes right out. And that's what you can see here on this normal slope. For an asthmatic, there's inflammation in the airway and constriction of the muscle in the airway, causing the airflow that's trying to come out to be slowed. And that's what you see here. The important thing is that for patients to get the diagnosis of asthma is if I were to give you a medication like an inhaler or albuterol, we can get better. And so your lung function improves after bronchodilator use. For some people, it doesn't go back to completely normal, but for some people it does. It's just the response to the medication that determines whether or not you have asthma. So when we look at treating asthma, the things that we do are twofold. The idea is, number one, to reduce impairment. So that means trying to reduce symptoms, things like the cough, the chest tightness, the shortness of breath, and the wheeze. And we try and limit the amount of rescue medications that are used for individuals with this disease. The important thing is that you're not waking up with symptoms overnight, so no shortness of breath, no wheezing at night. And the goal is to really improve the overall quality of life for people with this disease. We also try to reduce the risk of trying to prevent exacerbations, when what I mean by that is prevent episodes where the disease is worse. And the reason we do that is because we know individuals that have recurrent episodes where the disease gets worse or out of control, it's associated with kind of a slow lung function decline over time. Asthma management is a conversation with the patient and the physician. And the key is to try and monitor lung function and symptoms frequently to make sure that the asthma medication therapy that's being prescribed is beneficial in terms of symptom reduction. And the key is to provide self-management education. So we have a nurse educator who provides the ability to understand the disease process, but also to understand how these medications are used. We also try and treat the modifiable risk factors. For example, trying to get, if patients are allergic to pets, trying to keep them out of the room, as we already alluded to in the last talk. And I'll give you a quick anecdote. So quick story, when I was a very first year medicine resident, I had a severe asthmatic who was a young woman that had 6 cats. Now, she had a really bad cat allergy, and every time she was around her cats, she would get symptoms of her asthma. She'd wheeze and she'd feel short of breath. So how many of you in the room, with a quick show of hands, think that I was successful in having her get rid of the cats? Yeah, exactly. Not a single one, right? I mean, pets are family. So it's hard to get them out. So when I asked her, I was like, where do the pets sleep? She said, one sleeps here. One sleeps here, and the other are around the sides of me. So I was actually successful in getting the cats out of the room, but I was not able to successfully do anything more than that. But luckily, her symptoms improved with that alone. The other thing that we do in terms of treatment of this disease is actually to try and modify some of the other diseases that we know impact asthma severity. So those are the conditions that you're hearing about tonight, things like allergy and things like chronic rhinosinusitis, which you're going to hear about in the next talk. We assess patients for treatment, how they're doing in terms of their treatment. We step up treatment when we need to, and if you're doing well, we step down treatment, not trying to keep people on medications that they don't need. Very briefly, the medications that we use to treat the disease, the first one, the most common one, is a medication called albuterol, which is it's a medication that opens up the airway. It allows the muscle in the airway itself to relax. And this is a medication we use for patients for rescue treatment, as well as for pre-medication for people who have exercise-induced asthma. This is the most commonly prescribed medication for the treatment of this disease. For people that have more severe disease, the next steps that we use we use inhaled anti-inflammatory medications, which are called glucocorticoids, but those are used again for treatment of the underlying inflammation. And then finally, we have a couple other different types of inhaled medications that work in a long-acting fashion to open up the airway by causing the muscle to relax. We adjust these medications based on patients' symptoms. And for patients who have really severe disease, who are on all of these medications and continue to have symptoms, this is where a lot of our new biologic treatments are really impactful in the treatment of disease. Suffice it to say, we now have about 6 new biologic agents, which are either intravenous medications or subcutaneous injections that can be used for the treatment of inflammation in patients with severe disease. And these have revolutionized our ability to decrease symptoms, improve lung function, and actually decrease the episodes of exacerbations in a subset of these patients. So the idea in terms of getting patients under well control is to get them well controlled with asthma therapy. This means that you have very infrequent daytime symptoms, which are no more than twice per week, and nighttime symptoms no more than twice per month. The idea is that you're using your rescue inhaler very infrequently, and that you're able to do all the things that you find enjoyable, all of your activities of normal living, and all the things that you find to be enjoyable. When patients are poorly controlled, this is the key. This is where we need to make sure that we have optimized their asthma management, because have increased risk for impairment long-term, and then we have increased risk for exacerbations. And as I talked about, the biggest concern is that if we don't treat people with this disease properly, it can impact their lung function long-term. So I think in the last 30 minutes, I've tried to get across the point that asthma is a really common chronic respiratory disease, and it's characterized by airway inflammation and airflow obstruction. And what I mean by that is airway narrowing that's reversible. It's a complex disease with a variety of genetic influences and environmental exposures that impact the disease development, but also the disease severity. It's associated with poor outcomes during pregnancy and really must be treated with care during that time period. And then treatment of asthma really revolves around trying to decrease airway inflammation and decrease the airway narrowing that occurs in the setting of the muscle contraction. And where asthma has come a long way, I showed you the cigarettes that we used to treat asthma many, many years ago. Now we have a variety of new therapies that have been incredibly impactful in the treatment of disease. And I'm just going to say a quick thank you to my colleagues in the University of Colorado Asthma Research and Education, or UCARE program. Dr. Fernando Holguin, who you see here, who is the director of the program, Dr. Ann Fulbrigge, who is my colleague in the severe asthma program, Linda Ferguson, who's our nurse educator, who goes over asthma maintenance therapy, as well as the education surrounding asthma treatment. And then our incredible research coordinators, Vong Smith, Hope Cruz, and Nancy Perez, who make coming to work every day very fun. So thank you very much for your time.
So does everyone want to just stand up and stretch for a second? We'll just take a break, digest the information. I'd like to thank you all for coming this evening. Obviously, the weather is not ideal, but we can deal with that. And thank you to the Center for Women's Health Research for putting this together. I think you're going to see, I'm going to speak to you a little bit about chronic rhinosinusitis, and I think you're going to see some common themes with what you've just heard. This is a little bit different, but many of the concepts overlap, and how this affects women's health is what I aim to bring out a little bit today. So chronic rhinosinusitis, before I get into what it is, I went through, and I've been thinking about this for a while actually, went through some of the statistics, and when we look at the whole populations, what we see is that this disease actually likely affects women more than it affects men in several ways that we'll get into. These are the three largest epidemiology studies that have been done. This is a Canadian study from the National Health Service. This is the Allergy Asthma European Network from Europe, and then this is our National Health Survey in the United States. And there's quite a range of chronic rhinosinusitis prevalence from 5 to 12%, depending on how the questions are asked in these surveys. Most of the experts settle around about 10% prevalence, meaning if you yourself don't have chronic sinusitis and you know 10 people, you probably know someone with chronic sinusitis. This is actually kind of an interesting geographic phenomenon. In other countries where these sorts of studies have been done, it seems that the farther away from the equator you are, specifically the more north you are, I don't know that this has been done in very south latitudes, that there's a lower prevalence of chronic sinusitis. And we don't really know what that is, but it points to there being some geographic or environmental factor to this. Now, the other interesting thing here that is often ignored or in the research world has been sort of relatively downplayed is this does consistently affect the female gender more than the male gender, almost universally in every study. In big epidemiology studies like this is big in our world, in our chronic sinusitis world, seeing numbers like this, 60 to 70% female versus 30 to 40% male, that's actually pretty significant. And what I'm going to show you later is not just this idea that it affects women more than men, but that may be more of a problem for women than it is men. Okay, so what is chronic sinusitis? And this is kind of what I'm going to spend the bulk of my few minutes here today with you talking about is historically, we thought of this disease as something that just affects your sinuses, right? The sinuses, these paired spaces in your face, in your skull, around the nasal cavity. So that's what distinguishes this from allergic rhinitis or chronic rhinitis, nasal diseases. This requires inflammation of the sinuses. And the classic symptoms are listed here as facial pressure, discomfort, specifically not headache, but facial pressure, stuffiness or nasal congestion, nasal blockage of airflow, thick nasal drainage, often purulent or discolored, and a lost sense of smell, which is associated with a lost sense of taste. And this affects more often the maxillary or cheek sinuses, secondarily the ethmoid sinuses, the sinuses between your eyes, and the frontal sinus or sphenoid sinus in the back is one of the last sinuses that's affected. But generally, that's why people do this, the mask over their face. What's being more and more recognized now is not just the, not just the sinus symptoms, but some of the bodily symptoms that go along with this, and that's what I'm going to get into today. Pretty much everyone that I see who has this at some point or another in the discussion asks, why do I have this? And I think if you went to a sinus meeting, you could probably spend days going to all these lectures and still not really know the answer to that question. And it's sort of what we talked about in the asthma lecture is everyone gets to this endpoint in a slightly different way. So this disease is inflammation in the sinuses. This could be, at least in part, to smoking or air pollution or allergic inflammation, particulate matter. That's oftentimes we refer to that as pollution. That could be wildfire smoke or other irritant nasal inflammation. Viruses and bacteria are implicated in this. It could be something specific to you, the patient, and your anatomy. Maybe a deviated septum that does predispose you a little bit to chronic sinus inflammation. There's potentially some reasons why you get some inflammation, it doesn't go away. That's more of an anatomy thing, or the bacteria in your nose form things called biofilms, bony inflammation, or other things kind of going on in there. And then to a lesser degree, what happens here, when I say no, to a lesser degree, less frequently, what happens here is that you will start to get inflammation in the sinuses, and your body naturally should recover from that. And there are a number of states that certain changes occur, and your ability to recover from the inflammation is impaired. Some of those have to do with immune factors or how the cilia in the nose work, how what we call the mucosa or the lining of the nose isn't really doing its job. Stress is kind of interesting in that there's some bodily inflammation science that kind of goes on. This has never really been studied in the sinuses, but we assume people either perceive worse symptoms or actually do have chronic inflammation as a result of stress. The other thing that's interesting, similar to asthma and allergies, is it's a yes or no whether you have this disorder, but the range of how it affects you is quite broad. And these are CAT scans. This is one diagnostic test, one of the most common diagnostic tests. This would be like you looking at yourself through a window or in a mirror. These are your eyes. The white part is the skull, and the black is the air of the sinuses, the septum in the middle here. And this person just has a little bit of sinus disease here, this gray blob going on the frontal sinus on this side, but the rest of the sinuses are clear. This person has a little bit more sinus inflammation here in the central compartment, and it ranges to pretty severe, being totally blocked out. Or this is a unique kind of disorder where there's different sorts of mucus buildup, and it's kind of destroying the boundaries here between the sinuses and the brain. Ranging from this person to this person, you could imagine their symptoms are quite different. Their treatments might be more aggressive in this scenario, obviously. Okay, this has sort of been the focus of a lot of reading for me over the last few years because we're paying more and more attention to quality of life. Why is that? Is historically, we knew this was a high prevalence disease, and it was often blown off. And maybe your doctors even blow it off, including sometimes we do. We don't appreciate how much this bothers people. The classic symptoms like we talked about, blockage, congestion, discharge, facial pressure, reduced sense of smell. Not everyone is universally affected by all of these, but these are the most common symptoms. And then the other part that I want to get into today is what we call the extranasal symptoms. So even though this is a disease of the nose and sinuses, there are bodily issues that go along with this. And the most common one that people complain about is fatigue. Fatigue associated in and of itself, but also associated with loss of sleep character, sleep quality, and more recently there have been a number of publications that this goes along with cognitive ability. And you can imagine if you don't sleep well, you can't concentrate, you can't remember stuff, and you're just kind of affected in general by your quality of life. As it turns out, the cognitive part may not be totally related to the loss of sleep. So whether you sleep well or not, and you have chronic sinusitis, you still have a little bit, many people still have a little bit of cognitive loss from that, and that's a subject of actually a lot of research right now. Less commonly, toothache and ear pain, but sometimes this is lumped in here with symptoms. And what I want to get into today, these are sort of eye-opening statistics for me, and this is kind of a new way of looking at health and health-related quality of life. It's often lumped together in this term called econometrics. Health-related quality of life is sort of like your general state of health. Think back in your past to when you were healthy and how awesome it felt, you know, whatever age that is, right? It's like, wow, I could wake up and I felt great, I could do whatever I wanted. And then think of when you were at your most ill and how impaired you were. And that's kind of, you can rate those in a way. There's a way to do that. And this is sort of the general summary graph of this. Is in the U.S., this is a 0 to 1 scale. In the 0 phase would be you are basically so bad, that's death. And 1 is perfect health. In the U.S., the U.S. norm, meaning the average, is a 0.8 on that. So it's not exactly like you're 80% healthy, but like people rate themselves as generally good health. And as we see all the different diseases on the bottom here, chronic rhinosinusitis rates in here actually, it's not a competition, but it rates above. Moderate asthma, so similar ballpark. Near Parkinson's disease or coronary artery disease. It affects people more than congestive heart failure, COPD. So to me, when I first saw this, I thought, wow, that's amazing. You know, we are underappreciating how much people are bothered by this. Now, the second part of this is when we treat this disease, do we actually bring up people's health? You know, can we treat this and make people feel better? We think we can, but you know, is there a measure of that? So on that same scale, if you're able to make a change that's 0.03 or above, that's something that's considered noticeable. And the things that we do as surgeons, you know, and I'll get to this in a minute, is when we do surgery for chronic sinusitis, we always wonder how much better are people getting. And the minimum noticeable difference in your health, if someone's never had surgery before, you're able to roughly triple that on average. If someone's had surgery before and they're still kind of limping along, there are reasons to do it again. But these interventions are similar to coronary angioplasty or joint replacement. So these are kind of significant interventions. How big of a deal is this? In the United States, we talk about direct costs, the money you might spend going to the doctor or on your medications. This is estimated roughly at an $8 or more billion a year problem, chronic sinusitis. And then you heard about this a little bit is, I think what bothers people more is not just that they're going to the doctor more, spending more money on medicines and therapies, but that it bothers you all the time. And there's a way to monetize that and sort of put a number on it, put a figure on that, if you will. And that's actually more of a cost to you in this constant general nature than when you go to the doctor, when you go to the pharmacy. So people are spending $12 or more billion a year in the U.S. in lost productivity. In productivity at work, productivity at home, or your general leisure time based on how you value your leisure time. Where does that put you? This is refractory chronic sinusitis. This is actually more than severe asthma if you add in some of this productivity, meaning that the constant nature of it, I think, puts us above things. Asthma, chronic migraine, heart disease, diabetes. This is a big problem. These estimates were from 2007, so 12, 13 years ago, and we know, unfortunately, cost of healthcare has gone up, cost of medications has gone up, and so some of these, I think, are low estimates in the modern day, but people are spending on average $1,500 a year on medication costs, doctor's costs, and these indirect costs, missing work, not being fully functional at work, or lost household leisure time. The average here is about a month or so. Like this has been replicated in a number of studies. People are missing about 20 to 30 days a year of work from either acute exacerbations or not feeling well from this. Okay, so hopefully I've convinced you this is a big problem. A lot of people have it, and it affects you constantly a lot. So what do we do about this? When most people probably manage this on their own, but when we see people as physicians, we call that patients presenting for a reason. So when someone presents with chronic sinusitis, they're initially treated with medical therapies. And we teach the medical students there's kind of a general 80-20 rule. 80% of the time something works, 20% of the time it doesn't, we have to move on to the next thing. So the medicines, initially about 80% of the people feel okay on them and don't really need to progress to the next thing. If they're still bothered by it, then we call it refractory chronic sinusitis, and then we pile on more medicines. Or if the medicines really aren't doing anything, then we consider going to surgery and maybe continued medicines after that. This is a slide that I actually borrowed from our American Academy of Otolaryngology website, and so it's got a little bit of doctory jargon on it, but it really explains kind of what's happening here and what are our points of intervention. This is a CAT scan like you just saw, so relatively normal sinusitis, a little bit of inflammation here. But the point is your sinuses drain into your nose, and if you've got inflammation and blockage here, you sort of have to get rid of that to get better. Okay, so mucosal lining, meaning the general lining of the nose and sinuses, gets congested, or maybe you have an anatomic issue that sets you up for not clearing a cold or something like that. The opening or ostium is closed. Stuff in here can't really improve or restore to normalcy. So mucus sits around, the local environment gets more and more inflammation. The cilia, or the lining itself, the ability of the lining to sweep away mucus, stops in that scenario, and the lining gets more and more thick and inflamed, leading to more and more blockage, and this cycle keeps going. Now, this is a very simple way of thinking about it, but this is what we try to do with our medicines or surgery, is try to intervene in this cycle. So what are our options? For acute inflammation, meaning stuff that's like going on right now, generally we either are treating them with antibiotics if we think bacteria is a problem, antihistamines if we think allergies are a problem or some of the symptoms are histamine related, or decongestants, just trying to get things open. This is a disease of chronic inflammation, so most of the time the mainstay of therapy is antibiotics if you need them, and then things that decrease the chronic inflammation. Nasal steroid sprays like Flonase, Nasonex, Nasacort, that sort of thing. Sometimes oral steroids to really get more anti-inflammatory action. Or in particular situations, these drug classes may be useful. Leukotriene modifiers, that's drugs like Singulair or Zyflo, in particular for people with asthma, coexistent. In Europe, or in countries where surgery is not really easy to obtain, there have been some trials on particular antibiotics that also have some anti-inflammatory properties. These would be drugs like clarithromycin, the macrolides, or doxycycline for polyps. In 6 to 12 weeks of daily therapy at low doses, some people get significantly better. As soon as they go off those antibiotics, it tends to kind of go back to where it was. It's not a permanent fix, but maybe an option for some people. These have long been controversial as risk factors for chronic sinusitis. And so I told you at the beginning, everyone kind of gets to this point from a different path. So if you also have coexistent reflux, or a patient also has coexistent reflux or allergies, then we tend to add on those therapies. It's not a universal, everyone gets that. I will put in a plug here for saline rinses as a mechanical way to cleanse the nose or remove inflammatory stimuli for just about every cause. This is like the sinus rinse or neti pot, or even at a bare minimum, a saline spray. This therapy has gone back thousands of years, and this is probably the single therapy with the most data of efficacy in chronic sinusitis. So this would be considered like an A+. Everyone has to do this, or try to do this at least. Okay, so in the next kind of phase, I sort of walked you down that algorithm. Let's say you as the patient or we as the provider have tried the appropriate medicines for you, and you fall into that 20% that's not kind of better and you're sort of wanting to do more. This is kind of an interesting subset of patients. It's a large subset, 20% actually. But these are actually patients who are coming to the doctor a lot and are significantly bothered by it. And what's interesting about this is the people who are coming more and more are not necessarily bothered by the nasal part. The extra rhinologic symptoms seem to be the main driver of people who are coming to the doctor a lot or wanting to progress to the next level, namely surgery. And as it turns out, when you do the quality of life analysis with their symptom analysis, these are the patients who perceive more of a burden on their quality of life. I mentioned this earlier, that's namely number one is sleep, associated with fatigue, concentration, and cognitive loss, and productivity loss. This is unique to the United States. I think there are many countries where people are less obsessed with their productivity. And this is actually an interesting statistic that came out of these studies is we think of, if you have generally good health, we think of people who have problems sleeping as having sleep apnea, or that as being our number one disease of sleep. And people with chronic sinusitis actually have worse sleep than people with sleep apnea, or similar depending on what study you see. And then these are the patients who are more likely to want to progress to a surgical intervention, given all else the same. Okay, so think of that same statistic. Our US norm is at 0.81. If we take people who are going to surgery, so this is a select group, people who are bad enough that medicines don't work and they want to progress, do we actually bring up their health? Yes, I showed you that we get a 0.03 to 0.06 at 1 point improvement, but actually over the long term, so people in the short term, you should get some pretty quick improvement, right? There's a wide variability in disease, but you should get some pretty quick improvement if you're a good candidate. And over the long term, a mean of 5 years later, we're able to bring people close to back to the US norm on the whole, right? Not everyone gets the slam dunk result, but on the whole, pretty good. Okay, so let's go back to think about this then for the outcomes. We'll dissect out the outcomes for female gender versus male gender, and what are we specifically talking about here? Okay, so let me walk you through this. You don't need to worry about all this right now, but let me walk you through this. We participate in a multi-center study on outcomes, these are data from actually my patients. And this is representative of 2 other studies actually that we'll get into. And one of the other studies, we haven't presented this, but I was looking at this actually specifically for this talk. But I was sitting in the audience when this study was presented, and it was nearly identical. Let's look at this first. And so in the audience, these are all ENT physicians who are interested in sinusitis. They put up their data, which matches this, and this is the symptom score. And what this shows is that of all the women who that surgeon, or this was actually at the Mayo Clinic, a couple of surgeons at the Mayo Clinic, of all the people that they treated with surgery, the women that were treated with surgery had significantly worse symptom burden. And there was a little buzz that went around the room, and it was sort of like, very elementary and kind of childish, like ribbing of all the women physicians were like, see, look, we can deal with it. All the men are coming for surgery with less disease because they can't handle it. And actually all the guys were kind of like, oh man, that's probably right. And then they showed their data, which matches ours here. So these are the objective measures on the physician side of how much disease that person has. And in my patients, so this is an N of probably about 150 to 190 in each group. And they have comparable measures of disease that we measure on an endoscopy score when we look in their nose and on their CAT scan. And so the buzz kind of quieted, and then the guys were like, oh, see, we all have the same amount of disease, and women complain about it more. And, you know, it was sort of like an interesting talk, but the conclusion was sort of, we all kind of were scratching our heads like, why is it? This doesn't make sense at all. And so this has been now 2 studies, and our own data actually go along with this, is that women have higher symptom scores despite comparable or maybe even lesser levels of disease by our clinical measures. Now, if you dissect into this, the symptom differences here were more of the rhinologic, the local symptoms. So one kind of theory here would be that, okay, well, you know, maybe this has something to do with our gender roles, and the not sleeping and cognitive abilities mean that women are going to be bothered more by it than men or something like that. And it really wasn't borne out in this. This is purely local symptoms were worse in women. So these are some of the questions that are still ongoing in the literature that we're kind of interested in now, is that do women and men just decide to go to surgery at different points, right? This is a very self-selected group, people coming to us asking for surgery, and we're just looking to see who they are. And that could be for a lot of reasons. That Mayo study actually looked at this as a possibility is we saw earlier actually higher prevalence of allergy and asthma in women, and there's a higher prevalence of coexisting migraine headaches in women. So those could explain a little bit of the higher symptom burden if we're not accounting for allergy and migraine. The Mayo Clinic study did account for that. I don't have all that data on whether people have migraine headaches or not in my own population, so I can't do that. But this is one possibility. I'm actually most interested in this. I think there may be a similar amount of action going on in there, and it's more burdensome locally for women because there is a known female gender nasal sensitivity. What does that mean? This is just kind of a nice pictorial diagram, right? This is your nose, this is the mouth, this is the brain. If something's going on in your nose, how do you sense that? How do you know that there's something there? Pain or congestion? How do you feel that congestion, let's say? There's 2 main nerves that innervate the nose. There's the olfactory nerve, that's how you smell, smells olfaction, and there's a trigeminal nerve. A trigeminal nerve does a lot of different things, including, let's just say, general feeling, so general sensation. And these are 2 things that actually give you not just the feeling, but actually give you a mechanism of local inflammation. As it turns out, it's been known for a long time that if you take a woman of a particular age and an age-matched male, that the woman is going to be more sensitive if you subject them both to the same amount of odor testing. So I don't know does everyone know that? Like, women actually do have a better sense of smell than men on the whole. Several points, many studies on this. So the conclusion, we don't know why that is. There's a lot of possibilities, but at least the olfactory nerve is more sensitive. And there's a group actually out of Germany that has studied this for the trigeminal nerve. It's a little bit harder to study, and they found the same thing. And we don't need to get into this, but basically they did various studies, these are human studies, they did various studies to actually try to activate the trigeminal nerve. And women's trigeminal nerves are activated at lower thresholds than men. Don't know why that is, it just is. And to me, that all kind of makes sense here. So that explains some local symptoms, same amount of disease, but you might perceive it as more of a problem. And, you know, some people might say, like, okay, that's great. You know, you try to explain why, like, okay, but does it really matter? How's this all going to play out in the end? And as it turns out, if you have surgery, how it all plays out in the short term is a little bit different, but in the long term, kind of everyone gets to the same point. So this was from that Mayo Clinic study. Although women may present for surgery with worse symptoms, early on, like almost immediately post-op, a couple weeks later, they get similar results. Men tend to hang on to their good result for a little bit longer, but over time, everyone sort of gets to the same endpoint. So when we're doing surgery on people for chronic sinusitis, as a whole, women and men are kind of getting comparable long-term results, at least in this one study. Okay, so I'm going to kind of wrap up there and leave us a little bit of time for Q&A. I know that there's a lot of different things we could go into in chronic sinusitis. I think one of the take-home points I'd like to leave you with is these aren't just sinus problems. I don't have chronic sinusitis. I know about this now, actually quite a bit more of the burden part of it. My brother has chronic sinusitis. Like, he goes to work and does all the normal stuff, and I kind of feel bad. Like, I never really appreciated how bad it was for him for so long. You know, even when he wasn't sounding stuffy or blowing his nose, he was probably suffering, and maybe he doesn't even really realize it. The systemic burden outside the sinuses is a big driver of quality of life, is a big driver of people seeking the next level of care. And most of that is sleep loss, cognitive loss, which is kind of interesting. We don't think about that a whole lot. Gobs and gobs of direct and indirect costs, especially as healthcare costs are going up. So lots of room for benefit here. This is a heterogeneous disease. You've heard the term heterogeneous a couple times, and it's sort of thrown around a lot, but basically people suffer from this disease in different ways. But at its core, it's a disease of inflammation in the sinuses. There are multiple options for treatment. It's treated in the same way, trying to relieve the inflammation, get things open. People may seek treatments for different reasons, and patients and likewise clinicians need to understand what that driver is and how to best get there for that management. And what we're trying to do is take some of these symptoms and patient desires and try to create a better understanding and prediction models for people who might get their symptom improved by X, Y, or Z therapy. And it's an idea of bringing this concept of personalized medicine into chronic sinusitis. Not everyone has the same disease. Not everyone's going to get the same result from every intervention, although it is kind of a standard algorithm you'll be offered by your doctor. At some point, we may know this is more likely to work for you than this. You'll try this. The next patient might try that, and then we'll kind of change that a little bit. Hopefully, we get there. I think I'll end with that and leave us some time with questions for the group.
I want to thank our speakers. They are tremendous. It was really interesting and very educational. I just want to tell you that our next event is June 4th, and it's not for you all, it's for our high school girls, for Girls Career Day. We have 50 high school girls come in and experience all kinds of career opportunities and choices that they learn about, and it's always a very exciting day. We're going to be announcing it next week. If some of you are interested in having a daughter or another high school student that you know participate, please let us know, and we'll try to work with you. In the fall will be our next Let's Talk presentation. We're deciding right now what our topics should be and the date, so please give us your topic ideas. They will be considered, and we'll pick one, and we're looking forward to seeing you back in the fall for that. But let's take some questions and answers, and thanks again. Oh, okay.
Will these presentations be available to all of us?
Sorry?
Will these presentations be available to all of us who've attended?
Yes.
Great, thank you. So my question is for Dr. Sharma. So a little bit selfish on my part because I'm asking because of a family member. You mentioned that albuterol was a rescue medication and that if it is used incorrectly, it could impact lung function long term. So could this lead to something very serious like COPD?
Can you hear me? That's an excellent question. So one of the things that we've looked at, so the question is, I'm going to make sure I'm going to answer the appropriate question. So the question is, can asthma and treatment of asthma, if we don't do a good job of treating asthma, result in a more significant disease long term, like COPD? Is that correct? Excellent question. So I will tell you what we know. So if you follow people with asthma long term with kind of serial measurements of lung function, there's a variety of different trajectories that we can see. For some people, so everybody in this room, as you age, one of the things that happens is as you get into your mid-20s, your lung function is actually growing. So your lung function improves up until about the age of 20. And then at that point, it plateaus, and then because of age, every year we lose a little bit of lung function. So what we know is that if we follow asthmatics over time and we follow those measures of lung function, for some people, the rate of decline is more steep. And that happens especially with recurrent exacerbations, which means that for periods of time the disease is getting worse. What we know is that treatment with some of the anti-inflammatory medications and some of the newer medications actually improve lung function. So the reason it's important to make sure we've got the appropriate treatment for patients with this disease is to blunt that decline in lung function over time. What's even more impactful, though, is for some people, you don't actually get to that high plateau. Like, as you age, for whatever reason, whether it's intrauterine smoke exposure, for example, or early life exposures, you don't actually get to that highest peak of where your lung function should be. And so for those people, if they have even higher rates of decline in their lung function, it's a markedly bigger deal. And so we know for a subset of asthmatics, they develop chronic obstructive pulmonary disease, where we can give medications like albuterol and they respond initially. If their lung function declines over time, their response rates can go down. And it's why making an assessment early on when people start developing symptoms and making sure we're on appropriate asthma management and medications is essential for the long-term health of the lung. Does that answer make sense?
Yes, I mean, so essentially no one should just take it daily.
Yeah, so that's a great question. So if you're using your asthma inhaler frequently, so a couple times a day, more than that, even daily, we would recommend actually having somebody start on an anti-inflammatory medication. So the risk of using that medication more frequently is that we're not treating the underlying disease properly.
Thank you very much.
Hi. This is a question for Dr. Kalra and Dr. Ramakrishnan. I don't know which one to direct it to, but I'm asking because I'm a mother of a 10-year-old son who is incredibly allergic. He has asthma, tremendous food allergies that he requires an EpiPen for, and eczema, and oral allergy, you name it, he's got all of it. His doctors had put him on Zyrtec. Every night I gave him a Zyrtec. We've noticed cognitive problems, but he also has chronic rhinitis or rhinosinusitis. My question is this: is it the Zyrtec causing the cognitive problems? As I know that it's prohibited for my husband to take it in his line of work, or is it the cognitive issues and things that he's experiencing, maybe more a result of the chronic rhinosinusitis? Because he says, "Mommy, my brain is foggy, and I can't think. My brain doesn't work, and yet I know he's very, very bright." And we were seeing a lot of behavioral issues. I was wondering if you have an answer to this one, maybe.
That's a great question. I'm sorry that he's experiencing that. It sounds like you're asking whether if it's the Zyrtec that's causing the issues, or if it's the chronic allergic condition that's causing the issues. I think it's very well could be both. In terms of Zyrtec, so in terms of antihistamines in general, just for the general audience, the only antihistamine that does not cross into the blood-brain barrier is fexofenadine or Allegra. So there is absolutely no potential for drowsiness with fexofenadine or Allegra. Generally, Zyrtec and Claritin, or cetirizine and loratadine, are non-sedating antihistamines, so generally should not cause drowsiness. In some patients, Zyrtec can cause some drowsiness. So typically what I mean is, falling asleep during school, or having, some drowsiness sleepiness associated with it. We don't tend to see antihistamines causing behavioral issues or cognitive dysfunction. It's possible that it could be more related to the underlying conditions that are maybe need some additional treatment, because as you've seen today, certainly ongoing allergic rhinitis, allergic conjunctivitis, food allergy, especially with concern for food avoidance, things like that, can really impact not only daily performance at school, but also can really affect self-esteem. And so it very well could be a combination. You can always talk to your provider about either discontinuing Zyrtec or switching to fexofenadine. I don't generally see pediatric patients, so I can't advise you in terms of specific medical recommendations, but I would discuss that with your provider, as it may be a combination of different issues.
How long can one take Flonase or use nasal saline sprays?
Okay. The question was how long can you use nasal saline and nasal steroids? Or maybe how long, how much? Nasal saline, you can't use too much of it. So rinse or spray as much as you want. You could do it all day long if you wanted to. Nasal steroids, I had patients that do like 5 or 10 a day double rinses or something because they just like it so much. That's rare. But nasal steroids, I've been around for 20 to 30 years, and at least in adults is safe for chronic use. Local irritation, like if you're getting nosebleeds or dryness or kind of tenderness or something, you might want to try a different nasal steroid or maybe a slightly different application. Instead of spraying it to the middle, spray it to the sides a little bit, maybe a little bit better tolerated. Very little of it, like almost immeasurable. Now it's measurable with very, very sensitive assays. But very, very little of it actually gets into your bloodstream. So if you're spraying a steroid in your nose, there's kind of this stigma with steroids. You don't want to take steroids for too long. Tiny, tiny, minuscule amount into your bloodstream, so low risk of side effects from that.
I just wanted to ask, when you were alluding to different types of sinus surgeries, what exactly are those that you would recommend?
Yes, so the degree of sinus surgery varies, and it's sort of something like taking an appendix out, where you go in, it's like one surgery, your appendix is gone, and that's it. Everyone does the same thing. There's a little bit of subjectivity, meaning as surgeons, we try to address the disease, and maybe there's a little bit of different skill between your surgeon or different understanding of what you actually need. So conservative sinus surgery would be if someone doesn't have a ton of inflammation, sort of anterior stuff, maxillary sinus, maybe front of the ethmoids. More significant sinus surgery would be opening and cleaning out everything. Someone has already had surgery before, a bad nasal polyps, sometimes we do a little bit extra, try to get a little bit extra durable result. So there's kind of a spectrum of like just barely doing a little bit to being very aggressive. The other thing that people confuse with sinus surgery a lot are fixing a deviated septum or maybe surgery on the turbinates, sometimes done for allergy reasons, although that's not a great indication for it, but just to get airflow in. So it's kind of, sinus surgery is sort of a broad term, wastebasket term for a lot of like subtle decisions that go into that. Does that answer your question, sort of? What would I recommend? It depends on what the goals of the surgery are and what the underlying disease is. Usually a CAT scan guides that.
So part of the process is like scraping the inside of the sinus?
Not anymore. That was kind of so like, thankfully we've gotten better at sinus surgery over time. The common belief that's kind of widely held is sinus surgery is super painful, and the goal of it is to scrape everything out, and it's called the Roto-Rooter. We try to not actually propagate that idea. It's not really what we do anymore. The idea is to remove some inflamed tissue, open the sinuses very widely, and as it turns out over time, this has become obvious, is that if you can remove the stimulus for inflammation and allow the nasal rinses and nasal steroids to get in there better, your body's ability to regenerate a healthy lining is better than our ability to scrape it out and start fresh. Which is, I mean, that's logical. I see people nodding along like, of course, yeah, duh. But the second thing that goes along with it is the scraping of stuff is what's painful and causes a lot of bleeding. So if you've had sinus surgery or you had a friend who had sinus surgery 20 years ago, their experience is going to be different from what someone has now, assuming your surgeon is using modern techniques and that sort of stuff.
So,
Which is hard to know, actually.
so I have a question for each of you. And when we talk about sex and gender, and I tell our board this, but a lot of people don't know, I'm very involved in the Office of Research of Women's Health at NIH, and sex differences are those biological differences, like the X chromosome and the Y chromosome, and gender is more the psychosocial differences. So when we talk about sex differences or gender differences, what would you say, and it might be that not much is known in your particular field about that, but of your observations or particularly your evidence-based knowledge, what's the biggest difference between men and women in your area for each of you? You can start.
I need some time to think about this.
That's known.
I would say the biggest gender difference, and I've alluded to this here, is the expectations for outcome. So I'm a surgeon, so I deal with this decision of whether or not it's wise to proceed with surgery. And for me, I think in my own data, when I look at it, is people actually come to surgery for different reasons. That's what I alluded to here. And I think for women, there's a little bit more of pain and headache. And for guys, it's a little bit more of, I can't sleep and can't breathe out of my nose, it's stuffy. And my job for the patients is to try my best to predict if your reason to go to surgery is something that will get better. And it's not, I mean, there's a little bit of science behind it, but it's hard to predict that. On the sex-based biological part of it, I don't think we really have a good handle on it. We know this is a standard answer, and this is kind of a sad state, is we know that there's estrogen receptors in the nasal mucosa and sinus tissues, and there's a little bit of a different steroid response based on the estrogen receptor kind of local makeup. But we have no idea if that means anything. I don't know, I think we just kind of sad, but when we see or hear the word estrogen, we think like that's a sex difference or biological difference. I don't know what that actually means, so we're kind of missing, and we've got a lot missing there, actually.
Well, it's a call for more research, right? So that's a good thing. We'll be busy in our lifetimes. Anjali?
I think Dr. Sharma and I both talked about this, but in terms of sex differences, we tend to see that males have a higher predominance of allergic disease and asthma prior to adolescence or puberty. Afterwards, females have a higher prevalence of allergic disease and asthma. With regards to other types of diseases that are not allergic disease, for example, food intolerance, we tend to see some gender differences there, more common with female gender versus male gender, but we don't know a lot about why that is or much about gender differences when it comes to allergic disease specifically.
That's a great question. So in addition to some of the stuff that I alluded to in my talk about the impact of intrauterine exposures during pregnancy resulting in the development of asthma, I would say the other kind of interesting sex-specific difference is in obese asthmatics in particular. So the obese asthmatic who has adult onset disease and is female, this subclassification of patients is the hardest to treat. And our lab, actually, our group looks specifically at this patient population because it's associated with poor asthma outcomes, increased symptoms, and increased exacerbations and healthcare utilization. And if you look at the specific group of individuals, so it's the young, obese, asthmatic female, when we look at the difference in their airway, they actually have different processing of oxidative stress. And we think this is related to difference in the airway and the way the airway handles inflammation. And I'm making it a little bit simplistic, but it is the way oxidative stress and its role in the airway changes in that patient population. And we're trying to identify some specific therapies for this patient population.
Thank you all. I would hope maybe if there are a few questions, people can talk to you briefly, individually. And thank you so much. It was really terrific. Appreciate it.